Quentin, Peter, thank you so much for coming on today's episode, which comes on the back of some data I shared of yours, which caused quite a stir. It got some heated discussions going amongst the GP community to the extent that you were asked to delete some of your analysis. But of course, the NHS data that you analyse is huge, and you've clearly done a comprehensive analysis, which we'll dive into. But before we do, let's start with a bit about your backgrounds and what inspired this project in the first place. So, Peter, let's start with yourself.
Thanks, Gemma. So I'm a 25-year veteran of the NHS, and I've had an interest in health inequalities for a number of years. Part of that is about looking at funding. Deprived populations have a unique set of needs, and there's some really clear evidence that says funding needs to follow that need. The practical frontline experience is that it doesn't, and that's the bit that interests me. I've been doing at-scale primary care health inequalities for over a decade now.
Thanks, Quentin.
So I taught chemistry of all things for quite a long time at university, and as a consequence of teaching forensic science students, I slowly drifted over into doing more and more data science-y type things. It's a long story for another day. This particular project was to try to collate a lot of NHS transparency data. And the original idea was to try to see whether it was possible from publicly available records to then get an idea how different regions were being funded, the outcomes that were being attained, and look into it that way. So that's sort of how it came to be.
Okay, all right. Well, thanks for that. I guess really we should start with the graph that I shared on my LinkedIn, which was, the graph that caused the stir. So, Peter, do you mind sharing that graph and just walking us through it?
So we do have a chart here, which I will bring up there. So this is a graph that shows deprivation ranking. So the higher up a practice sits on this axis, the wealthier the area. This is based off LSOA data.
Okay. And I don't think we see that, Peter. Are you sharing?
Does that come up?
There we go. It's thinking about it. There we are. There's the graph.
Okay, so this chart, somewhat controversial, but based on publicly available data. So the y-axis here shows the deprivation ranking score, which is nationally determined. The higher the ranking, the wealthier the area. There's about 6,500 GP practices in England, and they're all ranked according to deprivation. The x-axis here shows pound per registered patient, and this is where the controversy sits. So there's some clustering in the middle, but what we can see is that there are some very deprived practices who are not receiving a huge amount of funding. There are some really quite wealthy areas that are receiving quite a lot of funding. And this is the root of some of the inequality that we see, and practice to practice variation, I believe, can be explained by a lot of the information that's shown within this chart. Now, Quentin is a much more statistically rigorous individual than I, and this was the kickstart for a really deep dive into this data.
Yeah, just to comment about this, as I recall, this is for a particular region. This is around Chesterfield, is that right?
So this is a snapshot for Derbyshire.
Okay, so this shows all of Derbyshire.
Yeah.
So it's a bit interesting. So Peter and I had a long discussion with a fellow colleague of ours that I'm working with at the University of Derby to do some of these things. And that led me to look deeper. So Peter suggested that I go and look at some other information. I just need to see if I can find this here. Actually, why am I not getting my entire screen? So I'm not seeing my tab. Let's just try doing. I'm going to have
So
to.
whilst Quentin, whilst you're looking for that, Quentin, this is all publicly available data, and you've managed to extrapolate that data in a way that brings more clarity to how GPs are paid and how much they're paid and the disparity.
So what I did is I went and hunted for some more data. And the data is provided by NHS, and it covers a period for 22 and 23. And I understand that the updated version for 23-24 hasn't been released. And there's lots of people who are kind of complaining a little bit about that. To be fair to the people who criticize, so I think this is a version of the plot that caused a bit of the controversy. And the thing that you see is on this axis is a metric from a file provided by the NHS trying to give information about GP funding. And the y-axis is per patient income, which includes PCN. So a PCN is a primary care network, workforce and support. So it includes some additional things. When I started looking through the spreadsheet, it's an awful spreadsheet. It has 75 different columns to choose from. And there's 4 or 5 different columns related to average patient income of various types. And so I just chose one. I chose not to include COVID-related patients, funding and things like that, and came up with this one that includes the PCN in it. And what is, I still find this an extraordinary plot. So at one end, you have a practice that is getting close to £1 million a patient. It's a strange practice with a quarter of a patient. So no, it didn't get a whole £1 million, but it probably got about $250,000. And there's a set of about 40 practices that are getting over £1,000 a patient. And then you've got this broad middle along the way, and then there are these falling off a cliff. The thing to remember, though, is that this is a logarithmic plot, so you don't see any of the ones that are having to give back money. So when I looked at this, the thing that struck me was this sort of set of extremes. And what I did is I just said, all right, the top half of GP practices are getting on average £1,290 per patient, and the bottom half is getting about 1,000 or 128. And that's a huge difference. The thing when started getting pushback that I thought people were complaining about was the fact that I was doing this average of averages rather than the median. And the average for the top half is so extraordinarily skewed by this group at the top that it's a little bit misleading that you have that number there. And I think that's a number that a lot of people latched onto. So does that help to explain where we got started in this discussion?
I think it gives us a good start. Yes, thank you.
Okay, so here's where the kickback really comes. And I think there's probably 4 main parts of that kickback. And the first one has to do with the column that I chose. And people said that this includes PCNs. And primary care networks are separate from GPs. Peter could perhaps give a few moments just describing what a PCN does versus a GB practice. I'm not somebody who's been intimately involved in this. So do you have a few words that you might say about them?
Yeah, so a primary care network is supposed to be individual practices coming together to provide at-scale services, which should therefore bring some economies. Separate conversation about whether that's actually being delivered. Their finances are complicated, and there's different models in which those services and those finances can flow. So in fairness to the people that kick back, including PCN figures on a per practice basis is certainly a confounder. But it is in the official publicly available NHS digital data set, so we can't just ignore it. So primary care networks are a factor in this, but as Quentin will probably describe, it's possible to exclude some of these confounders and take the analysis forward.
Yeah, I think
Does
so.
that make much of a difference if you exclude them?
So that's what I'm going to show you next. So the next thing I did is I said, all right, we've got this picture with PCNs. Why don't I just sort the data on the average income per patient, not including this stuff, and then make the same plot again. And you get this sort of, I call it, it's growing a bit of hair on the way up. So what this is it's been sorted based on exclusion of the PCN costs. And then what I've done is I plotted the PCN cost on this axis again. So what you see is its sort position of this practice that is sort of sticking up here is somewhere around, I don't know, 4,200 in terms of the 6,669 practices that we're talking about. But then after you include the PCN, this one is going to be one of these relatively leading practices. There might be a variety of reasons why that happens, but mostly what it does is that it adds an additional cost that the GP practices themselves don't necessarily see. And so I can definitely understand why a GP working for an actual GP practice is saying, well, you know, all that money doesn't come to us. There's some things that PCNs do that we don't. There's the part that Peter was talking about, but it's a little bit different. So that was sort of the first level. So yes, it is true that the PCN is a confounder. I think if you're a citizen that's just interested in the overall cost of delivering GP goods and service to people, the PCN cost should be in there somewhere, but I think it's also fair to say that the GPs aren't necessarily getting that. Is that accurate, Peter?
Yes, it is, Quentin. So again, because of the widely different ways in which PCNs can interact with their constituent practices, you can't take that PCN money necessarily and say that's going into a practice in and of itself.
Okay.
Yeah. So then that was the first thing that sort of was perfectly fair as a pushback. The second one is, well, what about weighted patients? And the income that comes into a practice is based on weighted patients, not on the number of patients, if that makes sense. So weighted patient, a simple way of looking at one type of weighting is age. So near my house is the University of Nottingham. I live in Nottingham. And the University of Nottingham has a GP practice associated with it that has something like 45,000 patients. Those patients are young, healthy. I sort of think of my students when I was teaching at university a lot. I think of students as being tough as old boots. Then there's people my age who are starting to have more difficult long-term health problems. And so the type of thing that a GP is having to deal with in a university or primarily university practice is going to be much different than one who is serving, say, an elderly rural area. And so what we can do is we can then sort on the average income per weighted patient, and you get this sort of a thing. The thing that I start to notice is that broadly, this graph doesn't change that much. I think as you increase the consideration of the weightings and other related things, it does tend to flatten this out and make it a little bit more understandable at one level. On the other hand, there's still this bit dropping off, and then there's still this extreme here. So we've considered two of them. One is PCNs, and then the other is this concept of patient weighting. Is there anything else about patient weighting that you could maybe add to the picture for somebody who's listening to this?
So patient weighting, Quentin, is a really complicated area, and it's been somewhat controversial for a number of years. The original idea behind it was to try and reflect and adjust the funding between practices that deviated from a notional national norm, which kind of makes sense at a superficial level. The problem is the funding formula itself, the Carr-Hill formula, is now really not fit for purpose. So it waits for rurality, it waits for age, it waits for some other things like number of new registration patients, so that can benefit university health. So if you are in a rural area with an elderly population, your weighting factor is higher. And that isn't necessarily where we see health inequalities developing. They tend to be in areas which aren't particularly rural, which isn't to say rural areas don't have their own special and unique challenges. They certainly do. But on average, rural wealthy areas are officially weighted higher than perhaps an urban deprived area. And that's where we see the practical coalface problems with the weighting formula that arguably is not fit for purpose.
How would you change that?
Wow, big question. And certainly better minds than mine have been asked that one. I think we need to have a complete reassessment of the health inequalities. What are we going to prioritise? Why are we going to prioritise that at a national level? And probably start to pull in some really granular LSOA level data on disease prevalence and total burden to health service. So that is a complicated piece of work to do that. I think there's broad agreement across primary care, however, Gemma, that the Cahill formula is no longer fit for purpose. Good idea at the time, best stab available probably at the time it was done, but it is now, I would argue, actively discriminating against addressing health inequalities.
Wow, interesting. Is there any plans that you know of, Peter, to revisit that then?
Not that I know of, no.
Right, okay.
I think that it's good that he's mentioned this sort of rurality thing, because that was another thing that was raised. So there's two other things that are causing increased money to go into a GP practice. One is whether it's rural or not, and the other one is if it's dispensing or not. And broadly, there are some urban dispensing practices, but they're fairly rare. Mostly it's a rural circumstance. And so if you remember the shape of that graph that I showed you, at this end where it's starting to go up, there will be more rural practices and there will be more dispensing practices, but it's not enough to say, well, they're all going to be there. They're still distributed across that broad curve. And the other thing is that part of what led me here was some work that I did with a colleague who's now working at Derby on looking at population density effects on mortality. And we're trying to get information about morbidity, but that's perhaps a little bit too big for this conversation because it is, as Peter says, very complicated. It is clear that rural areas have particular health needs. And some of that is that the rural areas, at least in the UK, tend to be more elderly. And it's sort of funny, looking at some of the data, if you've seen the property things about escape to the country, it's like, no. You want to escape to the most population dense city that you possibly can, so you're stimulated and you have the economies of scale associated with it. So that's sort of a funny thing, but the rural and dispensing thing fits into that curve, and there were some people that mentioned that as well.
Well, that's interesting about your analogy to the city, because I live in Bristol, and of course we looked at my GP practice, and which I do moan about quite a bit for not getting an appointment, hence the post. But I can see how hard they're working. And when you looked at the data, I think they were being paid just £120 per patient. How can a GP surgery survive looking after patients on £120 per patient, especially if a patient is having an appointment several times a year, or they're having to go for checkups, for blood tests, for other tests? Like, how is that possible for a GP surgery to survive?
I don't know.
The short answer, Gemma, is it isn't, and this is one of the fundamental problems with primary care. The whole contracting structure, the whole payment system for primary care and the liabilities that GP partners hold is fundamentally flawed. So in my neck of the woods, the average per pound per patient is about 150 something pounds. You know, you're talking less than 50p a day. that's lower than cat and dog insurance for your pet.
Yeah,
And the number of consultations per patient is climbing post-COVID. Demand, for a variety of complex reasons, is skyrocketing. There isn't the capacity within the system to see everybody. And as a direct consequence of some of this funding lunacy, we're now in a situation where we have newly qualified GPs who practices cannot afford to employ. So that is why you can't get an appointment. On top of a prolonged, multicoloured political push for on-the-day access as being the most important thing, when all of the data from comparable populations in Europe clearly points to continuity of care being the thing that results in a lower total cost to the healthcare system. So less morbidity and less mortality. So we've got divergence between data and politics, and we've got a really clear problem with funding, and that's why you can't get an appointment.
Yeah, I think that fits with some sort of separate analysis. I came across a data set that had the number of appointments in December 2024 for each practice, and it was staggering to me. Again, it's one of these curves that, there's some that are up here and you just think, how is it even possible? And then there's others that are fewer. Again, these formulas related to age and health conditions and stuff like that figure into that. But it was again extraordinary. But overall, the typical GP has appointments sufficient to see every single one of their patients over 5 times a year. And when you do the sums, I don't have the updated data set, but using the previous year's sums that I was just talking about, you're looking at somewhere around £28 per appointment. And to put that in perspective, I was able, hallelujah, to get an appointment with a GP or an NHS dentist.
Congratulations.
And my copay on that was about £27. And so there's an additional payment, I believe, comes to that dentist in addition to that. But the copay for the dentist is roughly what the GP practice is getting per appointment on average. And it's not very much. I mean, when you think of the training and the requirements of it.
Going back to the data that you have, some of the pushback in the comments was around rent and rent reimbursements.
So that I've looked at less, but it's fair in that if one of the things that I think my initial belief would be is you should just go where there's more money going into the practice. And you shouldn't move to London for that reason. Let's put it that way, because of course property is more costly in London. The cost of property, related costs to a GP practice will tend to be more. So you don't want to move that. I think if I was trying to be, looking at my general area, all other things being equal, I'm in Nottingham and I've got 4 or 5 different practices that I could maybe squeeze into depending on their catchments. I would tend to go to the one that has the most income. However, there are some, a number of people that say, well, it's not as simple as that. So there's one other bit of pushback that I think I need to address as well, because again, it's fair. It's like the property costs. Those will vary across the country. Some places will have very high ones and others will be lower. There's also sort of 3 kind of incentive schemes. If I've understood correctly, there's QOF, which is Quality of Outcomes Framework. There's DES and LES. LES is Local Enhanced Service and DES is, Directed Enhanced Service. And so depending on what the GP practice is able to earn, so the ones that are making more to some extent can earn it more. And this is something that I might look at if I was looking myself into that data set, is a GP practice that is capable of earning more of these things probably has a little bit more about it. Again, Peter can correct me probably on this. And so they might be better able to deal. It doesn't mean that the GP practice that doesn't have these and doesn't have time for them, they just run off their feet all the time. isn't doing the best that they can. That's not the point that I'm trying to make. But I think if there is a practice that is capable of delivering enhanced services in this way, or meeting quality framework targets and stuff like that, might consider going to that, all other things being equal. The other thing it made me realize is that I'm pretty well off with my GP, and I'm going to stay with them. Yeah, it's not necessarily easy to get an appointment, but when I've needed it, I've got one.
What's your take on that, Peter? Would you say that it runs in parallel, so the level of service provided by a GP practice is equivalent to how much they're being paid per patient, would you say?
I think that's a tricky one. It might, and I think certainly at the extreme low end of not many pounds per patient, I would have a strong suspicion from 25 odd years at the coalface that practice is going to be a distressed practice that's going to struggle to deliver a service that you would want as a patient. How far up the curve you need to travel before you're getting a decent service, I think is where that curve probably starts to expand into a band. There are practices who are earning quite well, shall we say, who choose to take that out as profit and run a minimally effective service. And there are practices who choose not to take that out as additional profit and put more service in. So I think there's complexity in there. But down at the bottom end, I think there's a real concern that practices that are frankly underfunded, and usually these are practices in areas of high health inequality, they're going to really struggle to deliver an effective service. And that, I think, is an area that's well worth focusing in on.
And are you able to see that with the data that you have? Can you see what GP services have taken money out for profit and provided minimum service?
No, because if you think about it, the GP contract for partnership is a lousy business proposition. So nobody is going to let anybody anywhere near that information. So we have proxies. So there is an open source data set from HMRC that reports partner income and salaried GP income nationally. There's a degree of accuracy to that, but it isn't that accurate. So you would have to composite a huge swathe of publicly available data and see what that showed. The reality is, I have left the cult that is the NHS now outside of that and having the freedom to comment. Every GP knows the practices that are doing better than they should be in terms of taking money out. And everybody knows the practices that are struggling. And then there's the group in the middle that are doing okay. You're not
that particular data set I haven't seen. Yeah, so thank you for pointing that out. Maybe I'll hunt that down at some point and try to do something with it. But yeah,
I'll look forward to sharing that data then.
Yeah. So there is one other thing related to this sorted data set that I think is worth talking about. So the part that still gets me, and I think when I wrote my original posts and probably when you reposted it, what I didn't word it as well as I should. So the thing that I really wanted to be saying is I think most GPs are working really, really hard. I personally don't have a problem with them earning a bit of money. That isn't my main beef. I think if, there's no more money to be had, yes, we should have some discussions about this, but that's not really where I'm coming from. But I'm still, this bit that's over here just is bothering me and has for a long time. So I talked to some people, and there are a few things that explain some of it. So there are about 6 walk-in centers that fall into this data set. So it's perfectly fair that those walk-in centers would have 0 registered patients. If they had registered patients, it doesn't make sense for them to be a walk-in center. So those sort of make sense to me. Some other people pointed out that there are a few of these practices, if you look carefully at their websites. Again, there's 6,669 of them. I didn't look at all of them. I did look at a few, but some of them people had sharper eyes than I did. And they pointed out that some of these are serving very difficult to reach populations. So some of them might be working with homeless people, drug addicts, people in care. And one of the things that I think is really great about what the NHS is that it really is for everybody. And yes, I think if people can't get to a GP or can't find one or something like that, you can get through the cracks, but everybody is served. Whether you're a drug addict, whether you have no fixed address, any of those things, you still need care. And if those practices that specialize in that get a little bit more, I don't have a problem with that. Okay, that's the good side. The bad side, so last little bit. In that data set, there's 206 practices with 0 patients. Of those, there's about 6 that are walk-in centers. 171 of them are closed. Of the ones that closed, there were a few that closed during the 2022-23 period, which that data set is from. If I then exclude those, there's 107 practices left with 0 patients, and those attracted 37.8 million of funding. In the grand scheme of the NHS, that's not huge, but if somebody gave that to me, thank you very much, it would be life-changing. Just in case, so I pointed this out to some people that I had some chats with, and they said, well, if a practice is merging or closing down, there might be some residual payments. All right, let's go back and eliminate anything that was after 2019. So only practices that closed 2018 or further back. There's 30 of these. And in that data set, the 30 got a sum total of 26.2 million. I can't explain this. Nobody can explain it. Perhaps somebody in the NHS can even tell me whether that spreadsheet is right, because some people seem to think it's not. I've had some people say, you should bring up NHS fraud. And when I get a spare minute, I will. But it's just one of those things. So what I, as a academic, is we see things that stick up and are interesting, and we just want to pull on them. And so that's sort of what I've done. And so in fairness to the people who push back, 100%, it's not obvious that the most strongly earning practices are the ones that get the least per patient. If you work with a university population, that can be a pretty good gig. If you're at the top end and you're dispensing practice out in the middle of nowhere, it can be still a very difficult thing to make the ends meet. So it's not as simple as I think we originally made it, and that's fair. I'm grateful to the pushback, and that sort of is most of what I wanted to say about the data. There's another bit that I think Peter's talked about that we need to talk more about. And we need to just park that entire data set, and we need to talk about the GP contract. So
well,
Peter,
I was going to ask you.
Tell me about it.
Yeah, that was going to be my next question to you both. I mean, do you think they're realistic? I mean, given the workforce pressures at the moment, everything that you've shared, do you think GP contracts and targets are realistic?
It's not so much the targets, Gemma. Quentin, let me make you a business offer. I'd like to take a contract from me. It'll be 98.5% of your total income. I can change the contract at will in any way, shape or form. If you sign up to this contract, you are personally and individually liable for failure to perform and going bust. Would you like to accept that contract?
Absolutely not.
That's
I
crazy.
touch that with a barge pole.
Crazy.
That's GP partnership in a nutshell.
Really?
That's unlimited liability. Yeah.
Yeah. So this week in the medical press, new GPs not that keen on partnership. No, really. Well, let's have a think why. Cost to buy in goes up. Income doesn't keep pace with inflation. Your house is at risk. Government, which is the other side of the contract, NHS England changes contract at will. You can do nothing about it other than hand it back. If you hand it back, you're personally liable for the cost of closing your own business. That's not a good deal. GPs in the main, not very good at business. They're in this to help patients. Genuinely, almost every GP I've ever worked with has been in this because we like helping patients. We moan about them occasionally, but by and large, we go to work to help people in life, not do business. But you don't have to be a business Einstein to work out that offer is not fundamentally a good and sensible offer in this day and age. 30 years ago, it was a different kettle of fish. But that's the fundamental problem. Add into that even if we accept the data set that Quentin's analysed, if we ignore the extremities, because it's a government data set, it'll be riddled with errors because nobody's accountable for it. There's still huge variation in pound per patient. You can't control that as part of your business. And if you haven't got the money to provide the service, it's you that gets the negative pushback, not NHS England. I think the whole way in which we contract for primary care is fundamentally flawed. It will hold the nation's health back, but we're not having a sensible conversation about it. And I think that's the fundamental problem with primary care. That's why you can't get an appointment.
I think even Peter's not even being strong enough about that. if just my opinion, in that I think of it's an abusive contract. In my view, it's this really bizarre insurance scheme where you have a really tight customer who dictates the premiums that are going to be paid to deliver an insurance. Most of what a GP practice gets is an amount per patient, and that's supposed to solve all those patients' problems for all the GP goods and services they want. So that's the first side. It's just sort of a crazy system. If I have, everybody in my area has got flu and norovirus in December, and I have to put in 18-hour days to see them all, I don't get any more for that. That's nuts. And then the part about unlimited liability, mostly I think this conversation developed on LinkedIn, and LinkedIn is for business people. And the number of business people that I know that are going to sign up to an unlimited liability contract is darn near zero. I wouldn't touch it with a barge pole. Would you?
No. I just don't understand how it is still happening. How is it allowed to be happening?
It's history that the regulatory framework doesn't keep pace with the change of things. 25 years ago, when I was starting out, GP partnerships were pretty solid. The buy-in costs were low. Over that sort of initial 15 to 20 years, you could see income rise. It was a solid proposition. The risk to reward ratio was favourable. Over the last decade, as we've seen practice income steeply decline, that risk reward ratio has changed, and it isn't getting any better, and building costs go up. The cost to buy in for a new partner in a decent surgery is really quite high, and we're not, in the main, GPs are not, in my view, well remunerated generally across the country for the level of risk hold that they take in managing patients and running that business. Hospital staff are really good because they're insulated from that acute spend outside of the C-suite, which has a different set of rules for survivability, and it's not your money and it's not your liability.
Yeah, and being a bit more controversial, even in one sense, I think one of the reasons why the GPs are treated the way they are is we think of GPs as the NHS. They are not. They are contractors. They're independent contractors. They are not the NHS. They serve the NHS, but they are not part of it. There's other parts of the NHS that really are part of the NHS, and you're working for the NHS, and the NHS pays your paycheck. But that's not true of GPs. They are a supplier. They are an external supplier. They are not the NHS. And people don't understand that, and they're forced to work under this ridiculous contract.
But it's a duality, because primary care is the NHS when it needs to be pressurised to be the NHS, but when something comes along like, an increase in national insurance contribution at the employer side, outside of the NHS, we're not funding you for that. So it is that duality. You can be the NHS when it suits whichever colour of government is in power, but you're outside of the NHS when it suits whichever colour of government is in power. It is a really dumb contractual position to be in my opinion. And for clarity, I have never and would never accept a GP partnership role for the reasons that we've articulated.
Is there some data which shows how many GP partnerships have been agreed versus X amount of years ago, or over the years, how it's changed? Is there any data?
There might be. I could try to dig it up. I know that some of them have closed because they're in this data set and some of them are still getting money. But I don't know how that has, fared over years, and tracking a GP practice over time, whether it's,
you can track GP partner numbers and you can track GP salary numbers over time. That data is available.
Okay.
And you can look at partner and non-partner incomes. But the problem is that this data is fragmented and a lot of it is kind of quasi-public available. You really got to know where to go looking and hunting for this kind of information. It's not, as lots of government data as it isn't obviously obtainable, despite technically, I suppose, being publicly available.
So as we come to a close on today's episode, then it's clear that you've done a hell of a lot of work on this. What are you hoping to achieve? What are the next steps for you now?
Well, let's see. I think I'll probably walk temporarily away from the GP thing because it's sort of a side project to something else that I'm doing. But I think for the GPs in general, one of the last points that was made in the comments that needs to be raised is between 2010 and 2024, we lost 3,694 GPs. Wow. At that same time, we gained 5,533 emergency medical practitioners. That's over doubled. At that same time, the population has increased. And relative to inflation, the amount that GPs are getting per patient has got squeezed. And I think we really need to have a national dialogue about this, because is there really no more money? If we're going to raise it through politicians, no, there's no more money. When I think of my home country, so I'm now a citizen of the UK, but I came from the States, the spend per person on healthcare is over double what it is here. And so we just need to watch ourselves, because on the one hand, if we just put all the GPs out of business, what are we going to be left with? We need a national dialogue about this, and the NHS needs to take it a little bit more seriously. And the GPs were saying, these additional GP numbers have been promised by politicians for years. And that's another aspect of what is making it so that you can't get an appointment easily and maybe don't have the attention that you need from your GP for more complicated conditions. It's just my opinion, but that's, I'd like to see GPs get a better deal.
Peter?
I'd like to see the 180 billion that's spent on the NHS spent more effectively. And I think Quentin is right. We need a national dialogue about how that's done. 6 or 7% of that 180 billion ends up in primary care. Yet 90+% of the activity takes place there. Primary care isn't necessarily exciting or sexy, but it's really effective at maintaining population health. And the difficulty has always been it doesn't get the right funding. It's easier for politicians and the medical politicians to put it into stuff that's seen as sexy, that gets you in the headlines, that is treating, rare cancers, the glamorous stuff. That isn't where the national wins are. And a national health service should prioritise the health of the nation. And I think there need to be some really, really blunt health economic discussions about where do we spend that 180 billion. I hold a view there is no more money. That 180 billion is an astonishing fee. And yet we do not have spectacular outcomes in the NHS. And
do you think it's enough? Do you think it's enough?
I think it's enough. The nation cannot afford more than 180 billion. It really cannot. We have to be spending that efficiently. And we're not, in my view.
Okay. Interesting. Wow. Okay. Well, thank you so much for joining today. One last question before I let you both go. Did you expect this data to cause such controversy and such a debate?
I was surprised, and so thank you for resharing it. So it didn't get the same attention in my feed. And to some extent, I'm a little bit disappointed in that a lot of the stuff that I put out on LinkedIn is things that I'm just trying to show people, and I wish people would push back more and give more comment, because I need it. I'm seeing this kind of, extreme lumpiness, for want of a better word, everywhere that I look in the larger data set that I've got, on the boil, so to speak. And so, no, I didn't, but I'm really happy that so many people responded, and they did it in a pretty good way. So thank you. That's all I can say.
Great. Well, I'm sure on the back of this episode, you'll get some more questions as well. So maybe, depending on the feedback, we'll get you back for some more discussions. But there's just so much we can talk about, isn't there? If you enjoyed today's episode, subscribe to our channel and share it with someone who might find it useful. You can find all the resources we talked about today, including links to the studies and tools, in the show notes on LinkedIn, X, TikTok and YouTube. Thank you so much for tuning in today. We really appreciate your support and love hearing from you.